relevant ear professionals ranging from audiologists, doctors, GPs, ENT specialists, ENT nurses. This is a very challenging case in both ears actually. So we're starting off, and this is the patient's left ear, and this piece of wax that I'm removing using an ear hook is probably the hardest single piece of earwax I've ever removed. The ear hook itself was actually almost about to snap. It was that much pressure I was having to apply. It was that hard and that lodged near the entrance. And if you keep watching in a moment, this piece of wax, you will see me hold it and drop it onto my medical trolley, and you'll hear yourself how hard a ping this earwax elicited when it dropped on the medical trolley. It was almost stone-like. It was a bit strange because the client themselves didn't really feel that they had many problems with their ears. Although this piece of earwax was very hard and solid, it was actually the opposite ear, the right ear, which we'll show you afterwards, which was the more complex one. And the patient themselves were, they felt they did notice a slight deterioration in the hearing, but it was more so their loved ones that were complaining, and it was quite surprising. Hi again, I had to pause myself, otherwise you wouldn't have heard the audio because that was a separate clip, but yeah, it was extremely hard. We're now doing the patient's right ear, and this ear, the wax is not as hard, but it's very impactful. It's a very challenging case for a number of reasons, and you'll see throughout the video. It's completely occluding right from the entrance of the ear canal to the eardrum. It's been there for a long time. I initially went in with as old a suction probe. The wax was a bit too sticky, a consistency to get a suction grip, so there was an opening at the roof of the ear canal, so I thought I would use a Jobson horn. And as soon as I went into the wax, I was hoping this wax, because it seemed quite like a fudge type consistency, and I was able to get the Jobson horn into the middle and literally pull the whole wax piece out in one go. But it's almost like a chocolate fondant. You go in, you break into the surface of the earwax into the core, the middle, and it's really soft and gooey. And you can see it's a bit gooey there. You can see the shape of the Jobson horn in the middle of the wax. So Jobson horn helped me initially, but as the procedure went forwards, it wasn't as effective, and I had to resort to an ear hook. Also now we'll put some olive oil drops in. So the olive oil is just designed to soften this wax, lubricate it, get a better suction grip. So we're still more or less near the entrance of the ear, just at the base of the ear canal here. The wax posteriorly, so to the back of your ear canal, so to the left as you're viewing, it's a bit blurry just because of the oil, so that's what happens sometimes. The wax more posteriorly was a bit drier and firmer, and there's a bit more skin adhesions. So this wax had a range of consistencies. It was fudge-like, very soft and gooey in the centre. Some wax at the posterior was a bit firmer and crusty, and it's been there for a long time. And that's perhaps why the patient herself had not really noticed a huge deterioration in hearing. She obviously noticed the difference after I removed it, but if earwax is accumulating very slowly over a long period of time, the patient themselves don't actually realise for them that's their normal hearing. Someone like, you can compare it to someone with a hearing loss who requires hearing aids. An age-related hearing loss can take up to 10 to 15 years to first develop, deteriorate to a level where the patient themselves are aware. And because it's such a gradual change, the patient is almost unbeknown to this slow deterioration. If they lost their hearing overnight, suddenly they have that reference point from the night before, and they'll realise that, yeah, oh God, my hearing has significantly deteriorated. And I suspect in some ways this is what's happened with this patient. This wax is almost black, so it's oxidised. We know it's been there for a long time. So I'm still working away, and it is challenging. unless you're performing the procedure, you don't realise how challenging it is. I think sometimes you view it, and I had a patient today actually, and they said that I was watching some of your videos, and kind of for them it's just obviously an image with an ear, and you've got a Hoover, and they just think it's straightforward because you just put a vacuum in the ear and you suck stuff out. And obviously when we did it in their own ears, they realised the complexity. Actually, the earwax is not as easy as I wish it was, because if it was, well, anyone could do it, I think. So don't be deceived by what you just see on the screen. You need to be actually performing the procedure. If there's any ENT doctors or audiologists watching this, they'll fully understand where I'm coming from when I say that. So again, I'm just working at the posterior part of the earwax, just trying to lift off the canal wall. Another way I can describe this particular case, if you've got a little tub and you get some margarine or butter and you put it into this little bottle or container and you really compress it with a spoon, a teaspoon at the top. So that bottle, that little container, is the patient's ear, and the contents, that butter, margarine consistency type of wax, that's what we need to get out of that bottle or jar. But we've got to do it obviously in someone's ear. So a bottle, well, we can put a lot of pressure in. That's not going to hurt the bottle. It might crack it, but not going to cause any bleeding or bruising or potential lawsuit against you from the bottle. But when we're doing that in a patient's ear, we've got to be really careful. And you'll see at the end of the procedure, there's a bit of blistering at the base of the ear canal. No active bleeding, it was just blistering, and it could have been we made contact with the base of the ear canal. I feel it's more to do when we remove this piece of wax, and there's a few skin adhesions, and those skin adhesions, as we elevated it off the base of the ear canal, it just caused a bit of mild bruising, blistering, but there's no active bleeding. You can see the wax here is a bit firmer and drier compared to the rest. It was a bit softer elsewhere. So again, I'm just going to the base, just lifting that up. There's a bit of keratin there. You can see the changing colour. It's a bit of a lighter brown, a bit of white there, and that's keratin, that's stuck. And this wax is lodged really deep, right against the eardrum. You'll see at the end of the procedure, the eardrum itself was slightly inflamed, so this wax was compressed against it. That's how bad the case was. We obviously gave some advice to the patient to attend far more regularly, and to instill olive oil earwax drops. In the UK, I generally recommend a brand called Earol. It's a spray. I find it's more efficient. It certainly helps me more during procedures using Earol than other types of olive oil based earwax drops that are on the market. I've not been paid or sponsored in any way by Earol to make that statement. It's just my own anecdotal evidence and experience, and I think it's important that I share that with the viewers, because my main aim is to make sure that everyone watching this and those suffering from earwax problems do get the best advice. But you may hear another specialist disagree, and they might prefer sodium bicarbonate drops. Now, I do recommend sodium bicarbonate drops, but that's for cases of keratosis obturans, which is when there's a formation, accumulation of dead skin cells in the ear, and it turns into a skin plug. I think sodium bicarb works really well with dead skin keratin. With earwax generally, I do recommend still Earol. I try to stay away from the hydrogen peroxide types of drops. I won't name any particular brand because I don't think it's fair, but I find that hydrogen peroxide turns the wax into a very mushy consistency, which keeps blocking the tube. It's very difficult to extract from the ear. So again, I'm just trying to, it's lodged. You can see the base of the ear canal there, and beyond that, this earwax is lodged. And if you remember, if you watch a lot of my videos, about a centimetre away from the eardrum, there's a narrowing and then a widening of the ear canal, and that's called the isthmus. And this wax is lodged beyond that narrowing. So when you get that narrowing, the ear canal then protrudes outwards, and this wax is compressed against the eardrum in that opening. And we're trying to extract a piece of wax through a large piece of wax through a narrow part of the ear canal. So it's kind of like, it is a tug of war, so to speak. Forceps wouldn't be suitable because the wax is too soft and mushy. I've used Jobson horn, I've used an ear hook even, and it's just perseverance really with these kind of cases. See, there's a few hairs there, and I know a lot of viewers don't like the hairs. They're not. I know they're slightly obscuring the view, but for me, the specialist, it's not really affecting me. So we're not. It's best left well alone. We trim those; they'll come back. They might even come back quicker, a bit thicker. You can also compare this to a piece of chewing gum that's kind of stuck to the sole of your shoe, and you're trying to remove that chewing gum. It's really sticky and elastic. As you know, it can be very, very hard to remove chewing gum off the sole of your feet. I think sometimes it's best to freeze it almost to make it really hard, and then you can pull it out. But that's the sole of your shoe, so again, you're not going to hurt the sole of your shoe. It's not going to put it to any pain when we're in someone's ear again. My utmost concern is to make sure the patient's comfortable. I mean, there are times that I think in this case I did say to the patient, I think, well, I'm just going to go a bit deeper. I think it's probably at this stage. It might be slightly uncomfortable, just pre-warn them, but I think their comfort and their well-being is my main prerogative and priority, and I'm happy to take a bit longer in the procedure if need be, just to cause any discomfort to the patient. See, we're tunneling through. Again, you normally hope you get this Jobson horn in, you apply a bit of pressure, you bring it out, and as you bring it out, the whole piece of wax comes out. So I'm just going anteriorly, trying to get in behind this dead keratin now, so I'm trying to get deeper into the ear canal, just trying to wedge it out. In some respects, it might have been easier to remove if the wax was as hard as it was in the first ear, because at least that way the objective then is just to get behind this lodge of wax, hard wax, and as you bring the instrument out, because that wax is rock solid, it is also going to come out with the instrument. When you've got wax like this, which is a bit sticky and soft, a bit like margarine or butter, whichever instrument, so we're using a Jobson horn at the moment, or an ear hook, it just slices through, and that's the issue. So do bear with us, guys. We do get this out in the end. You'll see we're a squeaky clean ear canal, and I'd recommend to watch the video because you can see all the contents of the ear and the tissue. You would have seen obviously that on the thumbnail as well, but we're not too far away now, so you can see the tip of the endoscope there. It's just a bit smeared with some wax. Again, just going with the Jobson horn, trying to elevate this forward. You can see just at the base there, as you can see, there's a bit of redness there, a bit of soreness. Wasn't active bleeding, you'll see that in a moment. It just seems like a bit of bruising, blistering. And again, that could have been, we just made contact with the Jobson horn. So again, when the ear is so blocked, when you go in with an instrument, you don't know how deep you can go safely because you can't see the ear canal, it's completely blocked. So it could have been that, or I've got a feeling it's more to do with, you saw earlier when I was elevating and lifting the plug of wax, there was a bit of keratin at the base of the ear canal, lighter brown colour, that was coating the wax. As we lifted that, it just caused a bit of blistering. So this piece of wax is a bit firmer to the core, so it's almost like a crust on the outside, and in the middle it was a core. Hence why I made reference to a chocolate fondant cake. These are the procedures where you have to be really, really patient. just the tedious ones. They can be frustrating to perform. But you do get, I could get quite a few of these kind of cases if I'm honest. I'm finding more and more now that I'm getting a lot more complex cases. Having people travel from further afield or getting referred from other specialists around the UK, which I don't mind. I think it's great. I enjoy doing the complex cases. Obviously, if I'm training people in the procedure, I need to be doing those complex cases on a regular basis. So, yeah, if you're an ear specialist and you have a patient that you're struggling with, feel free to refer onwards. I'm nearly there. Well, there's the eardrum now, so you can see the blistering just at the base of the ear canal. So there's no active bleeding there, a bit of dead skin. I'm not sure if I think I left that. So that's all the contents. I've got 3 still images from different angles. See, quite a lot of wax. One of those boulders were from the first ear, but the rest of it was from the second ear. That really, really impacted. It's up there with the most wax kind of removed from one ear. Hope you enjoyed that. If you're watching on YouTube, feel free to subscribe to the channel. Select the bell icon so you'll get notified as and when I upload new videos. If you're watching on Facebook or Instagram for the first time, again, feel free to like.